Let's proceed now and complete the dysrhythmias. So for ventricular dysrhythmias, we start with the PVCs. This is similar to a PAC. PAC was generally harmless, right? Unless they occur in succession or the patients get more than 5 per minute. So similarly, PVC is generally harmless if it occurs in a patient who is otherwise healthy, meaning no cardiac problems, no histories. The PVCs occur all the time. So you'll see that the causes are similar to those of PAC. Mentioned here are coffee again, stress, anxiety. Those are the most common triggers for a PVC. So if you drink more than a cup of coffee a day, then you probably have experienced PVCs. Okay, again, they are generally harmless unless they occur in the following. So if a patient has heart failure or tachycardia, then PVCs serve as a warning that a more serious dysrhythmia is about to come, especially if the patient is currently having a heart attack. So for instance, you work in telemetry, your patient is currently admitted for acute coronary syndromes, meaning they have symptoms of a heart attack. If they show PVCs, which we otherwise would not treat, just like PACs, these PVCs occurring in patients with active coronary problems have to be treated. Most treatments will involve beta blockers, as you'll see under the treatment. What do they look like? Well, it depends because there are different patterns to a PVC. A few mentioned here is, let's start with bigeminy. When it says bigeminy, that means a PVC occurs every other beat. Bigeminy meaning 2, right? So every other beat is a PVC. If it's a trigeminy, then it's every third beat. So that means it's sinus PVC. If it's bigeminy, then it'll be sinus PVC, sinus PVC. If it's trigeminy, then it'll be sinus, sinus PVC, sinus, sinus PVC. What if it's a quadrigeminy? What do you think the pattern will be? Okay, every fourth beat will be a PVC. All right. Now, that's one pattern depending on how often does it occur. There's also a pattern as to how many occur at a time. So when there are 2 that in succession occurring at a time, we call that a couplet, a couple. And then if we see 3 in a row, then that'll be a triplet. And what will we see? We call it, if it's 4 in a row, quadruplet and quintuplet, etc. But if it's more than 5, we don't do sextuplets and then so on. We call it now ventricular tachycardia. All right. So here are different patterns. So let's see if you can identify. What do you think the first one is called?
Right.
That first one on the
Right.
That's bigeminy. Very good, because it's sinus PVC, sinus PVC. What about the next figure? Particularly this one.
Right.
Right. No quad.
Why? Oh, yeah. No. Right.
Well, this one, let's look at this one, for instance. What do you call this one? This pattern? This would be bigeminy. How about this one?
Right.
No, tri is every third beat. This is 2 in a row. This is a couplet. All right. So those are examples of PVCs. Right. So PVCs do not look anything like a normal PVC. This is a normal QRS. These are normal QRSs. This is not a normal QRS, is it?
Because it's dropping.
Yeah, it's distorted. Okay. Now you'll see different types also. Let's say this one. This is another PVC. How did we identify a PAC again? What follows a PAC? A short pause, correct? So about 2 big blocks or more. This one, does it also follow a pause? Is it also followed by a pause? Yes. So every time you see a PBC, there's always a pause before the underlying rhythm resumes. So this one, that's a couplet, and then followed by another short pause, followed by a normal normal QRS. And then this one, does this look like these PVCs?
No, it's
These
upside down.
PVCs are the same, right? Meaning if they're the same, that means the same source is triggering this premature impulse. You understand? So it's the same one. Whatever cells or group of cells are firing these signals, they're the same because they look the same. However, this one, does it look the same as the others? So more likely, is this the same cells firing these premature impulses? No.
So can you go back to the quad, what, the quad?
If it's quadrigeminy, then it'll be every 4th beat.
So how?
We don't have an example here.
Oh.
If this was not 2 in a row, then yes, this would be considered a quad if it was only 1. But since it's 2, we don't call it quadrigeminy because it's a couplet. We worry again if we get 5 or more PVCs in a row, because that's what we call now a ventricular tachycardia. And you remember BLS? Right? Because is there cardiac output when that occurs? No more cardiac output. However, it has to be sustained though in order for it to drop cardiac output. We've seen people who have, let's say, up to 10 seconds of PVCs and they're totally fine. They weren't even aware that they had a VTAC episode occurring about 10 beats in a row. Oh, no, sorry, I didn't mean 10 seconds. 10 beats in a row, because those 10 beats could last maybe 3 or 4 seconds. So they're not aware at all of it happening. Most of the time they're sleeping or up brushing their teeth or doing something, watching TV. All right. So let's manage again, depending really what kind of PVC is the patient having. And it's also depending on whether or not the patient has symptoms and what the current diagnosis is. What's the patient's diagnosis as these PVCs are occurring? Okay, what's the underlying disease condition? If they are frequent and persistent, meaning they follow couplets or triplets, or let's say trigeminy, quadrigeminy, and it's sustained for a long time, and the patient is now showing symptoms, we treat them with amiodarone or beta blockers. They may be given by mouth or IV, depending on the patient's condition and depending on the patient's symptoms. And what did we say again about whenever we give antidysrhythmics? What do we always monitor? Okay, we will expect another dysrhythmia that could result from that treatment. As already mentioned, so this is the more serious complication. We don't want multiple PVCs in a row. So if they do occur, then we start to worry. Depending again if it's sustained or not. If they're short bursts, we call them paroxysmal. What does paroxysmal mean again? We mentioned this term last week. And it was defined on the paragraph. You know, remember in AFib, there were different types of AFib and there was paroxysmal AFib. What did this say about paroxysmal? Sudden onset and sudden cessation, meaning it resolved on its own. Nothing was done. It came on and then stopped spontaneously on its own without any intervention. So that's what we call paroxysmal. So if it's paroxysmal, we probably won't treat the patient, but we will monitor them more closely because one event could lead to other events. And you already discussed this in BLS. So how do we treat VTAC? Okay, remember Jim and what's the other guy's name? The black dude? Don't remember? Okay, anyway, there are two types of VTAC. There's a VTAC with a pulse, and there's a pulseless VTAC. So pulseless VTAC definitely is the patient conscious.
No.
No. However, if a patient has VTAC and they're awake, so what is your first action? Do you defibrillate?
Check the vitals.
Again, okay, so let's say Miss Kirko is the patient. You see her awake, but then on her cardiac monitor, she's showing VTAC. So what do you do?
Check the patient.
Because remember, there are two types of VTAC.
Check the patient.
Okay, that's your first action. Obviously, she's awake, so she must have a pulse, right? Okay, so just go on and check her pulse. You confirm it is a pulse. There's a pulse. So the management will depend. Pulseless VTAC, treat the same way as VFib, which is, what do you do first? What BLS? Come on, BLS. What do you do in BLS? Pulseless VTAC or VFib. What do you do?
Airway.
Okay, you call a code, right? Okay, you call a code first. Okay, you say you're in the hospital, so you call a code. This happens elsewhere, which is impossible because we don't have people on a monitor, right? In the shopping mall, right? So of course it's different. Then you call 911. If it's outside. In the hospital, patients already on a monitor. They're in VTAC. You check they have no pulse. So what's your next action? Okay, activate rapid response. Okay, so call a code, say whatever your facility's code is for cardiac arrest. If it's code blue, who works in hospitals here? What is your code? No, I mean for code blue. Okay, what about you?
7,000.
7,000. Okay, where's that? Outside. Okay, it's first thing I've heard that term. Well, it's also weird. In mine, it's 101C. What the hell is 101C? Flushing. Yeah. What do you mean it makes sense? What about 101C? It makes sense if it's in Flushing. Okay, all right.
Yeah.
So anyway, so you know what I mean, right? Okay, so it's the equivalent of calling 911. But since we're in the hospital, then there's no 111. We're it. Okay, so these are the medications. So if the patient has a pulse, so these are the medications. Otherwise, no pulse, then it's gonna be chest compressions, call a code, begin chest compressions, and as soon as the defibrillator is available, then defibrillate the patient. So here's VTAC. Okay, once the patient survives cardiac arrest, which is what happened here. So the patient either had VTAC or VFib and they survived it. So the recommendation after surviving a fatal dysrhythmia like this is an ICD. What is an ICD? Okay, so it's a small device. So it's a miniaturized defibrillator. So it has two functions. The device can detect the two fatal dysrhythmias, VTAC or VFib, and then deliver shocks. Of course, it's a small device. It's a small battery. So can it generate the same amount of electrical voltage as the defibrillator? Okay, but it will help, right? Better than nothing. So this is, again, if the patient survived one and the patient has a ejection fraction greater than 35%, then they are candidates for ICDs. We will not discuss Torsades de Pointes. Two reasons: it's not really a very common dysrhythmia, plus there's no strip on your textbook. All right, so we do have VTAC and we have a couple PVCs. Let's go to VFib. Causes, yes.
I have a question. I'm sorry. Is this on the quiz today?
No,
This-
only the one
Okay.
last week.
Yes.
We ended
Okay,
up
that's
to
what
a
I'm-
flutter.
Okay.
Yeah, don't worry. Don't get a dysrhythmia.
Don't get a district.
Okay, so VFib is the other fatal dysrhythmia. So similar to VTAC, this is managed exactly the same way. What's your first action if you see Miss Kirku in VFib? Call a code and then proceed with chest compressions until the always prioritize chest compressions. All right, so your patient's outcome, their mortality highly depends on effective chest compressions. Okay, don't worry about giving breaths. I mean, you know that, right? You don't have to worry about breaths right now. Just start compressing the chest. It should be good quality chest compressions to save the patient's life. Now, of course, that's granting you're aware that the patient is full code, right? So don't mess it up for them also if they have a DNR order or they have a DNR on file, and then don't mess it up for them. Don't start chest compressions when you shouldn't have started in the first place, okay? Because once you start chest compressions, can you just say, oops, and then stop? Okay, it's too late, okay? So it's a missed opportunity, okay? So you deprive them of their opportunity to go see their maker, all right? So you rob them of that opportunity. And can you be sued?
Yes, you can.
Yes, they'll sue you, okay? So they had a chance to leave and end all suffering. Then you extended that for them. You cruel. Okay, just kidding. I will skip idioventricular rhythm. Let's go now to asystole. So asystole, flatline. So how is this managed? No P waves, no QRSs, nothing.
Right, you just, tell the doctor, I guess, and the doctor goes on down.
No, I mean, your patient is in asystole right now and they're full code. So what do you do? Chest compressions, okay? Don't.
Even if it's a flat-
Yes, we do chest compressions, all right? Okay. Okay, now you know, okay? So please don't leave and then just call. Do chest compressions, all right? Unless, again, they're DNR, DNI. That's a different story. But full code, asystole, chest compressions, please. All right, are we okay? Yeah. All right, so please do chest compressions, color code chest compressions, okay? But no, that's the only difference. No shock because it's not shockable. All right, correct. So here are the various causes of asystole. Now, the first rhythm, once you start CPR, because it will generate a rhythm. So let's discuss why is there no shock advised in asystole? Because there is no rhythm. Now let's go back. What makes a rhythm? What creates a rhythm? There has to be contractions. Okay, so there mean that is there electrical activity? Yes. Okay, so yes, there's electrical activity. So therefore, if it's asystole, if it's flat, is there electrical activity? That means no electrical activity, no blood pressure, correct? Yeah. So when you start chest compressions, are you generating blood pressure?
Yes.
Yes. Is that blood pressure pushing electrolytes in and out of the cardiac cells?
Yes.
Are you generating electrical impulses now?
Yes.
Okay, so when you do, the first rhythm that comes back is either VTAC or VFib. Then what do? Then you can shock. All right. Okay, so it's very important to generate a rhythm first. So no shock for asystole, because if you shock them, what will happen?
They get a jolt and then they
No, you're literally cooking the patient. Okay, you're just electrocuting them for no reason. I mean, for what purpose? Okay, because you're a sadistic freak. Yes.
So you get it with them, then you shop?
Yes, that's why chest compressions only. Okay, very good quality chest compressions, and then it will generate electrical activity. It will generate VTAC or VFib. Then we can defibrillate.
Compressions, right? And then they bring like the machine and stuff,
Uh-huh.
and shock them, and if they don't like. jolt or
Again,
something,
only if the patient has VFib or VTAC.
Yeah.
Okay, asystole, what's the only treatment after calling a code? Chest compressions only. You will generate, don't worry, you will generate something because that manual compression will push electrolytes in and out. That generates electrical activity. And then the patient, once the patient is in fib or in VTAC, then we can shock. All right. Let's go now to conduction problems. When we say conduction abnormalities, this is referring to the SA node and the AB node. Because the SA node, once it fires, the electrical impulse is supposed to be received by the AB node and then transmitted, correct? To the bundle of His and the Purkinje fibers. Okay. So these problems, we have three, actually four. There are four problems here with conduction problems. Somehow, the electrical impulse from the SA node is either delayed or blocked as it reaches the AB node, meaning it's either delayed from reaching the AB node or it doesn't reach the AB node at all. Let's begin with the first degree. In first degree, this is generally harmless because this is only a delay. Because it's a delay, what do you think is the duration of the PR interval? It's going to be longer. Okay, so longer than what? How many seconds? It's longer than 0.2 seconds. Okay, so normal PR interval is between 0.12 to 0.2 seconds. Okay, so the reasons we don't know. It could be caused by medications or some abnormality in the electrical conduction pathway. Okay, so we'll look at the few reasons as we go through each type of AB block. So let's finish first degree. The only problem here is, again, it's delayed. Okay, so the PR interval is simply longer than 0.2 seconds. Most common, but if you look at the other characteristics, they're really normal. So they're, except for the rate. So the QRS is okay, but the PR interval is greater than 0.2 seconds. But in the first degree block here, there's really no block to speak of because what's the only problem here? It's a delay. Okay, so nothing is blocked. No PVCs, no QRS complexes are missing, right? Every P has a QRS, PQRS, it's complete. Okay, the only problem again is the rate because the PR interval is very long. No, again, there's no block here. It's only a delay. I don't really know why we call it a first degree block in the first place because there's really no block. Let's go now to second degree. Second degree has two types. We either call it second degree type 1 or Wenck-Back or Mobitz 2, second degree type 2. Let's look at type 1 first. Second degree type 1, this is the pattern. So you see PQRST, PQRST, and then what's happened? What happened?
Two P waves.
Okay, there's a P wave here with no QRS, correct? All right. But we're not missing a lot of those. As you can see also, the pattern is the PR interval is long here. It gets longer and even longer and then eventually blocked. Okay, so that's the pattern. Second degree type 1, the PR interval is long, gets longer, even longer, and then finally blocked. Okay, so that's the pattern in second degree type 1. I remember my instructor when I went to school, he compared this to a date, a relationship. So in first degree type 1, it's like me and Faith going out. Okay, let's say I have a date with Faith, but I arrive late to the date consistently. So that's first degree. I don't know if this will help, but it helped me tremendously. I retain information better. So in first degree type 1, I arrive every time we go out on a date. So let's say we have dinner dates every night. We're supposed to have dinner together every night. I arrive late, consistently late. Okay, I'm never on time. So that's first degree. Now in second degree type 1, every time we go out on our dinner date, I'm first day, Monday, I'm late. Even worse, Tuesday. Even worse, Wednesday. And then, do I show up on Thursday?
No.
No, I stand her up on Thursday. Okay, so that's second degree, type 1. Let's go now to second degree, type 2. In type 2, there is no lengthening of the PR interval. The PR interval remains the same. However, I have multiple stand-ups now. So there are multiple missing QRSs. So look at this pattern here. We've got PQRS, and there's a missing QRS here, correct? But the PR interval remains the same. Here's another one. Here's another one. Here's another one. Okay, so I have multiple missed dinners now with Faith, right? So that's type 2. So which one is worse, type 1 or type 2? Type 2 is worse because at least in type 1, there aren't as many missing QRSs. What's the importance of a QRS? What is a QRS again? What's happening when we see a QRS?
The contraction.
Of the what?
Yeah.
There is ventricular contraction. Why is ventricular contraction important? For cardiac output, right? So no ventricular contraction, then there's no blood coming out of the aorta or going to the lungs. So in type 2, what do you think is happening to the patient heart rate here? The ventricular heart rate in type 2. Is it still lower? All right, it lowers the overall minute by minute heart rate, ventricular heart rate. So is that significant? That's very serious because now the patient has lower cardiac output. Okay, patient will have symptoms here now of decreased cardiac output, the dizziness, the low urine output, the pallor, right? So the low cardiac sounds, changes in mental status already, decreased oxygenation. The patient has symptoms here now. So in second degree type 1, we typically don't treat this, but we monitor the patient. We try to eliminate. So here are some of the identified causes here. We try to eliminate those. Now in second degree type 2, because the patient now has a significantly lower ventricular rate, which is now in the 40 or even 30s, okay, high 30s, low 40s heart rate. So now the patient needs treatment. We'll get to the treatment when we get to pacemakers shortly. And here's the worst type of heart block, which is the third degree heart block. There are two terms to call this. We either use third degree heart block, or it's also called complete AV disassociation. Okay, again, this is complete heart block or a complete AV disassociation syndrome. Look at the third degree heart block. So if you, let's look at the rhythm using a Foreman's caliper again. Let's look at our E waves. So here's a P wave, here's a P wave. And let's see if the P waves are regular.
No. No.
Actually, it is. P waves are occurring at the same time. See, yeah, that's a P
Does
to
that one
P.
look like the one to the, QRS?
This one is locked, but this one, look at that. P, 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 P. It's regular. Let's look at the QRSs, the R waves. R waves, there's an R wave there, another here. Is it regular?
Yeah.
Actually, yes. Look at that. Yeah. Okay. So we call it a complete heart block because is there a P wave for every QRS?
No.
And is there a QRS for every P wave?
No.
No. So this means that let's go back to first degree. So in first degree, what am I doing during our dinner dates with my dinner dates with Faith? Coming late consistently. Second degree type 1, what am I doing? Later, and I don't show up. Here, second degree type 2, I'm missing multiple. Yeah, I'm missing multiple dates, dinner dates. And in complete heart block, are we still together?
No.
We call it quits. So Faith has had enough, broke up with me. So I'm doing my own thing. I'm the P wave. She's the R wave. So are we communicating at all? No, I'm doing my own thing. She's doing her own thing. Right? Because remember, is the AV node a pacemaker?
Yes.
It is a pacemaker. Is it capable of generating its own impulses? Yes. So here, which one is the higher rate here? The atrial rate or the ventricular rate? These are your 3-second markers here. Let's count the atrial rate between this 6-second strip. 1, 2, 3, 4, 5. So I have about 50 something, right? 50 something atrial rate. Let's count the ventricular rate. 1, 2, 3, 4, 5.
See a little bit.
Okay, almost the same. Wait a minute. Let's look at it clearer. Okay, here we go again. Anyway, so in complete heart block here, there is a complete disassociation between the SA node and the AV node. They are not communicating with each other at all. The SA node is firing, evidenced by the P waves that we see. The AV node is also firing, as evidenced by the QRSs that we see, right? But there is no QRS for every P wave. All right, is that clear? So the only treatment for a complete heart block is, of course, a pacemaker. Pacemaker can also be given to second degree type 2 because that, again, will drop the heart rate as well. But that's the treatment. Okay. Now, let's go to pacemakers. Until a pacemaker is given, though, let's say for symptomatic type 1, no, sorry, symptomatic second degree type 1, or even a symptomatic first degree. Because sometimes first degree heart blocks, very rarely though, have symptoms. So what drug can increase the heart rate? Okay, so we will give atropine. It'll be given IV. Yes, that's the dose. So here's the treatment for that's under sinus bradycardia. Okay, so here's the under AV blocks. So atropine, same dose, 0.5 milligrams. You can repeat it every few minutes. And if the patient needs a pacemaker, there is no such thing as a emergency permanent pacemaker insertion because we have a temporary pacemaker. So let's start with okay, pacemaker is another section. So let's just go down the chapter. Let's start with cardioversion and defibrillation. So remember this from last week? We managed atrial fibrillation and atrial flutter. What's the difference between these two? Okay, are they using different equipment? The same defibrillator equipment. What will make that equipment cardioverter versus a defibrillator? The synchronized button. Okay, so when you turn on the synchronized button, then it becomes the defibrillator becomes a cardioverter. So here's one major difference. See the timing of the delivery. So in defibrillation, when is the delivery of the electric shock given? On activation of the button. So once you press the button, then the electrical shock will be delivered immediately. What about in cardioversion? When is the electrical shock delivered? And it will be timed when? Randomly. When is it given? During which part of the cardiac cycle? Of the what?
Oh.
The clitoris, what? Peak of the R wave. Okay, so the peak of an R wave. Please don't forget to put gel, okay, so to minimize electrical shock injuries and make sure we have good contact with the skin. Please don't forget to apply gels, okay? Don't worry with the automated pads that we have instead of the paddles. They already have a gel in them, so no need to apply gel. And don't forget to yell what? Okay, so here's a review in case you've forgotten your BLS already in defibrillation. So chart 22-5. I discussed EPS last week. This is done before what procedure? This was mentioned under the catheter ablation paragraph, remember? So before we can do catheterization with ablation, we need to do an EPS first. Electrophysiologic study, here's the description to evaluate and treat arrhythmias. So they will show the doctor where the locations are of the cells and tissues inside the patient's heart chambers that are firing the erroneous or pathologic electrical impulses. Okay, so once they're located, they will be targeted for destruction. What will the catheter ablation do? They will use electrical waves in order to destroy the cells. Okay, literally burn them, destroy those errant cells. And here are the indications. So they destroy, yeah.
The first death cardiac?
Yeah, it's the same department anyway, so it's in the cardiac catheterization lab.
Oh,
So the same department. Okay, here's pacemakers now. So pacemakers can be temporary or permanent. There are two types of temporary pacemakers. The non-invasive temporary pacemaker is called a transcutaneous, meaning over the skin. So it's the same as in fact, we use the defibrillator as a transcutaneous pacemaker. So defibrillators can also function as pacemakers. So hospitals save money because we use the same equipment for defibrillation, cardioversion, and pacemaking purposes. So here we still put the same pads as we would defibrillate somebody, put them on the patient's chest, and then instead of shocking the patient, we will turn it on to pacing. So we will turn on the pacemaker function and it will fire small bursts of electrical impulses, 70 at a rate of 70 per minute. That's usually the standard, unless the doctor wants a higher rate, but most doctors will order 70 beats per minute. So that's your transcutaneous pacemaker. It can be used overnight, say 8 hours or up to 12 hours until we can do permanent pacemaker insertion the next morning. So all permanent pacemaker insertion procedures are done during business hours. You understand? So none will be done overnight. Like the doctor who inserts it does not come after business hours, right? Because there's no need, because we have a temporary pacemaker. Now, there are some instances wherein the patient will need a transvenous pacemaking. So in transvenous, this is the setup. The pacemaker is still outside. Oh, no, sorry. This one is a permanent one. I have no picture of a transvenous. Anyway, so a temporary transvenous pacemaker, the pacemaker is outside the patient's body. However, the wires are inside. So the wires will be inside like this. However, the pacemaker, instead of implanted in the patient's skin, it's outside the body. Now, who will get a therapy like this? Well, these are patients who are candidates for permanent pacemaker. However, we cannot put in a permanent pacemaker yet. The usual reason is the patient still has an active infection, meaning they have sepsis, they have endocarditis, which is our next topic during class today. The patient cannot receive a permanent pacemaker yet because there's an active infection. Because what will happen if the patient has a blood infection and then you put in a permanent pacemaker? What will happen to that permanent pacemaker?
it'll get infected. It won't work.
It will work, but it will get infected because the bacteria will turn it into a mansion. Okay, so the bacteria will grow on the permanent pacemaker because it's a foreign object. Will our body protect a foreign object?
No.
No, it could care less if something grows on a foreign object. So that is the same for central catheters, a Foley, any implants in your body, including a pacemaker or an ICD. So we cannot put it in yet until the patient completes the antibiotic therapy. So in the meantime, they will get a transvenous pacemaker instead, because we can't do transcutaneous for more than a few hours, because will that be comfortable for the patient to be constantly feeling electric shocks over their skin? No, that's completely uncomfortable. So transcutaneous only used for a few hours, okay, 8 to 12 hours the maximum. For transvenous, who gets these again?
People that's getting permanent parking.
Okay, that they can't get it yet. Okay, so let's call the term a bridge. Okay, what is a bridge? What is a bridge? Okay, so until you can get a permanent pacemaker, so this is like a bridge, all right? In the meantime, we'll use a transvenous pacemaker.
So they put it into like a they put the wires into like a catheter?
No, the wire goes through the patient's skin, so we'll just tape it, and then they carry the external pacemaker. Permanent pacemakers. So these are implanted. They stay forever unless, again, something goes wrong or these things get infected, which is rare. Then we'll take them out. The batteries last perpetually. Well, it depends on the patient's age. So the younger you are that you get a pacemaker, then likely you'll need a battery replacement during the rest of your life. But for older people, I mean, they're already 70 years old. What's the likelihood that they'll live to 85 with these cardiac problems? Probably not, right? But if it's a younger patient, then yes, they'll probably get a battery change 1, 2, or even 3 times, okay, in their lifetime.
With a pacemaker, is that one of like those devices that you're able to, like the doctor is able to monitor your cardiac rhythms or?
No. A pacemaker, again, what's a pacemaker? So let's review. SA node, AV node, right? Bundle of His and Purkinje fibers. What do? They fire electrical impulses. So that's what this machine does. So the device fires electrical impulses to start a heartbeat. Okay. So they need monitoring once a year at least, but if they come in with a problem, they're investigated again to see if it's a pacemaker failure issue. But otherwise, no events, then they'll get it checked once a year. There are 2 giant providers in the country. They corner the market. It's only St. Jude and what's the other? Medline, I think. Yeah, but I know St. Jude is the biggest company. Some pacemakers, some modern pacemakers are no longer made of metal, so they can be safe with MRIs, because that's the problem with pacemakers. So the older ones are made of metal, so they can't get MRIs at all. But the modern ones are metal free now, so it's safe for the patient to still get an MRI. We have a whole chart or table. No, it's a chart on what to teach the patient with a pacemaker. We'll get to that shortly. So there are 2 general settings in a pacemaker. So they're either set to fixed, also called asynchronous. When we say fixed or asynchronous, that means regardless of the patient's SA node function, the pacemaker, it will take over. Okay, it will override what the SA node is doing. It will generate the impulses. Okay, so we call that fixed, meaning the patient's heart rate will be 70 at any given time because the pacemaker is on fixed or asynchronous. They can also be
baseline.
Right. No, not baseline, intrinsic. Okay. Meaning the patient's own SA node will be disregarded. The pacemaker will override whatever it's doing. It can also be set to on-demand pacing or demand, simply demand or on-demand. That means it will only fire if the patient's heart rate falls below a set rate. Usually, again, the setting is around 70. So the patient's SA node fires less than 70 per minute. That turns the pacemaker on. Okay, the pacemaker will start firing. Okay. We can also have dual function devices, meaning the patient will have both an ICD and a pacemaker at the same time in one device, rather than having two separate devices. Okay, so that makes more sense to just have one. I won't test you on, well, there is a question. Okay, so on pacemakers, so there's not a lot, there's a few complications related to pacemaker, and you can also put this under ICD. So same complications, no need to study ICDs separately. Most common is local infection. So a patient just had it inserted and the site got infected. So in that case, then we'll take it out, put the patient back on a temporary pacemaker, treat the infection, and then start over. So that could take weeks or months. Pneumothorax, because the insertion site is just under the skin. So sometimes the doctor, especially during local anesthesia injection, when they put lidocaine in, the needle goes too deep and then punctures the pleura. Okay. Bleeding, or the pacemaker just fails. Or here, very rare, phrenic nerve, the phrenic nerve innervates the diaphragm, correct? So if this is a complication, the patient will have hiccups nonstop, meaning the diaphragm is irritated and will keep contracting, manifested by the hiccups. I won't test table 22-2. As I already mentioned, pacemaker surveillance is once a year, or sometimes depending on the patient's symptoms or age. The patient's pacemaker may be checked twice a year, or once every 6 months. Here's the ICD. Who gets an ICD? So there's a question on your blueprint, indications for ICD. So who gets it?
People who survive sudden cardiac death.
Okay, can we go by the paragraph? So who gets it? Starting
Which is
here.
at high risk for VT, fibrillation, and who would benefit from the ICD are those who have survived sudden cardiac death, which usually is caused by ventricular fibrillation or have experienced spontaneous symptomatic VT.
VTAC, yeah.
Keep on? Oh,
Yeah.
not due to a reversible cause called a secondary prevention intervention.
Okay. Next, who else gets it? Patients with
Coronary artery disease who are 40 days post-acute MI with moderate to severe LV dysfunction. Ejection fraction is less than or equal to 35%, are at risk of sudden cardiac death, and therefore an ICD is indicated.
Okay, pause for a minute. So these are patients who survived the heart attack, had a massive heart attack, they somehow survived. Because a large part of their ventricles died and are now scar tissue, is the cardiac function still normal?
No.
No, those dead cells are still around and they don't function. So therefore, is the conduction continuous throughout the ventricles?
No.
No, so that will create a scenario for dysrhythmias, most particularly VFib or VTAC. Okay, so once that happens, continue. But it has to be after 40 days because you can't put in an ICD less than 40 days because is the scarring already finished? No. So you have to wait until the healing is complete. So this is about 40 days after the heart attack, okay, before you can put in a ICD.
And ICD implantation is also recommended in patients who have been diagnosed with non-ischemic dilated cardiomyopathy for at least 9 months and have functional.
Class 2 or class 3 heart rate. Okay, let me just show you what dilated cardiomyopathy looks like. Look at this heart. So the one on the right is a dilated cardiomyopathy. Does that look like a normal heart to you? The walls are thin, so is this heart able to sustain cardiac output, to sustain life? No. So it's as good as gone, right? I mean, this is a no good heart. It's not going to function normally. It can't. You think this patient will live a normal life? Can they walk around like you do, go up the stairs, walk from the train? No. They'll have significant symptoms. So these patients, until they get a heart transplant, in order, if they still want to live, then they better get an ICD, right? Okay, remember the bridge we talked about earlier in transvenous pacemakers? All right. So if the same thing happens to patients who require an ICD, but they have an active infection and therefore we can't implant an ICD yet, right? Okay, so we have an external ICD. So this is a very popular brand, LifeVest. It's literally a vest. So made of canvas, they wear it on their skin. You put your clothing over this, so you can't put a shirt and then put this on. So you put this directly on your body, on your skin, and then you can wear a shirt over it. So these are the electrodes here, and then this is the external battery. Okay. The battery will fit in one of the pockets here. There's a pocket somewhere here. So you put the battery there so you don't have to literally carry it. Then you just walk around with this thing. It will still sense a dysrhythmia. Once it does, it will fire electrical impulses. Yes.
You put this on the patients, right? Or do we carry it around?
No, they put it on. So do you see good compliance with this therapy? I mean, imagine you, Faith, if you have to wear this. Does this look sexy?
No.
Is it comfortable?
Everybody.
So is there good compliance with this therapy?
No.
Is there good compliance?
No. I mean, unless they really wanna live.
People don't like to wear this. So when I visit homes and they have a LifeVest ordered, I see them like in a pile of laundry or under newspapers. So when I ask the patient, hey, why aren't you wearing your vest? It's somewhere there. Right? It's very comfortable. I mean, you start sweating, right? Let's say it was in Florida when I did home health care. So you think this is comfortable to wear in tropical weather?
No.
You sweat, they itch. Yes. No more than anybody else would. No, it wouldn't attract now. No. Just like anyone, let's say if you depends on, well, this is a smaller battery. Yeah, you will feel the shock, but it won't kill you. I mean, just like if you touch someone who's getting defibrillated, so yeah, you'll get it too.
Would it cause any damage?
Depending on the joules. You wanna find out? Okay. Alright. Okay, let's go now to your teaching. It's a long. Oh, you know what? I just remembered they took out the chart on this edition. I don't know why, but the teachings are under several paragraphs under nursing management. So let's just find them. So here's the first one, this paragraph. What do you teach the patient to report?
Incision site.
Swelling, tenderness, unusual tenderness, drainage. Okay, so those are signs, obviously, of an infection. So here's one. So this obviously pertains to if the ICD or the pacemaker was just put in recently and the incision hasn't fully healed yet. So you inspect the incision site for the following. Okay, specifically for ICD, is it scary knowing that this device will electrocute you? Okay, so you reassure the patient about that because can you experience VTAC or VFib during sexual activity? In these patients, remember, they just suffered a heart attack, they survived. Remember, Ms. Morris was reading the indications, who gets these things? Okay, so can it occur during sexual activity? Yes. And will that scare the partner? Like, I don't want to get electrocuted, but how do you reassure them that these are not like the 110-volt outlet? Okay, it's not like that. You'll hear, you'll feel a little no jolt, but it's not going to literally electrocute anybody. All right, so just reassure them. Or because that may discourage them from being intimate altogether. I mean, is that healthy for any relationship? No. Yes.
So you advise the patient not to try or
I know there's really only for the first few because they're really restricted from raising their arms up whenever you have an incision on your chest. So but that's only until they leave the hospital. Typically, when they leave the hospital, they're fine. But I mean, are you really, who gets this again? Patients who had a heart attack, are they really in the mood to drive? Don't worry, that's not really a concern. Yeah, most of these people just want to stay in bed because they'll be so weak. Okay, fatigue. I mean, it's not easy living through a heart attack. Yeah, I mean, remember they had chest compression, so there's a lot of injury to the thorax. Okay, if you've ever experienced manual chest compressions, has anyone been revived here? No. But anyway, if you talk to those people who survived chest compressions, it's not easy. Okay, they're very weak, pain all over. Yeah. Did I answer your question? So here, reassure them about because they may be tempted to just not do anything at all, okay, because of fear of triggering an event. Okay, we're not done yet. There's so many here. Okay, there's a little bit of summary here, chart 22-9. Let's look at. Okay, so we talked about the incision. Well, I don't know which ones I'll copy and paste on the exam. So this is a select all that apply. I wouldn't memorize. I mean, memorization is very.
Memorize, understand, like not just memorize.
Okay, yeah, if you want to call it that. Okay. So here, avoid spandex. I know you like wearing spandex, Miss Begum. So here, no soaking in the tub. This is until the incision heals. Okay, so until this incision, the staples and the stitches are off, then don't soak in the tub. Don't put any powders, lotions there. The restriction again, so about 2 weeks. Okay, so they can't raise their arms above their heads. No heavy lifting for a few weeks. All right, so don't use this only for the ICD, okay? It's the same restrictions, same teachings for a pacemaker, right? So for what are electromagnetic devices? What are these referring to? Here, so avoid large magnetic fields. What equipment contain magnetic fields?
The airport one, right?
Only those? Just the airport screening devices? What about things around your house? Which ones contain large magnets? Microwaves? What about speakers? Yes, speakers, yeah, how they emit sound waves, they use magnets. Okay, there are, so if you have old speakers and you want to get rid of them and you want to extract the magnet, there are magnets inside, powerful magnets inside speakers.
What the new iPhone, they got that magnet.
All, yeah, they always have, yeah, so communication devices, because they have speakers too, right? Phones have speakers, so they have magnetic
So when a
magnetic
patient,
fields.
when a patient dies, right, and they still have the ICT placed inside. Cause I seen it happen, someone had to come and like turn it off with a magnet. like,
Yeah,
it was
we
a
turn them on.
circle. So even if the patient's heart starts beating or whatever, the ICD still continues to send
Not an ICD, because ICD doesn't do that. It's a pacemaker.
the pacemaker.
Yeah.
Okay, the pacemaker will still send the
Right.
fire the.
Okay, since you brought that up, let me show you the rhythm. So if a patient has a pacemaker, instead of
Cover a magnet with their heart. you mess up.
yes, literally. Okay, so please look at this rhythm here. Do you see P waves?
No,
Why do you not see P waves? No, there are, where's
The first one?
first or second? Do you see P waves?
no. I
Uh-uh.
don't see any.
No P waves there.
None of them cover in 3 boxes.
So these spikes here is what is supposed to be the P wave.
Upside down.
Yeah, so these are now the pacemaker firing them. So the first one is atrial pacing. So instead of seeing the P wave, you'll see a pacemaker spike. So we call this rhythm atrial pace. Second one, the B, is ventricular pace. Instead of seeing QRSs, you see pacemaker spikes, B spikes. All right, so that's what you see. Atrial pace. You actually have there should be a label here, right here. Atrial pacemaker A, and then B is ventricular pacemaker. Okay, so first one is atrial pace, atrial pacing. Second one is ventricular pacing. So on the rhythm, that's what you'll see. So no more P waves, and no more, depending if it's a atrial or ventricular pace. Then if it's ventricular, then you see QRS. Yeah.
Oh, you know someone has a pacemaker.
Yes, sir.
If they're already set to a certain number, they're not 7. Let's say a non-invasive procedure like the colonoscopy. Would the heart rate drop?
No. It's usually not affected unless you give. I mean, it won't. No, because the pacemaker is in charge. Yeah, it's not. Yeah, it's not gonna be affected by drugs anymore because
Okay,
it's
so
a
she said-
device.
He said once the device sees that it drops, it sends it fires the thing.
Depending also on what type of setting it's on, whether it's demand or fixed or asynchronous. No more, because if it's on fixed, remember the SA node signals will be ignored. It's now the pacemaker that's in charge. So let's finish the teachings. So avoid large magnetic devices, obviously large speakers, or like you said, security devices at the malls. Well, as long as you're not close to the stage. Oh, that's fine. I mean, that's just the sound waves. It's not really the electromagnetic waves. Now, for the, so here are examples: large motors, welding equipment, electrical substations, we see throughout the city. So stay away from those. They emit large magnetic fields. Yeah, so those substations by Con Edison, wherein they have large, they usually put it in an entire block. Yeah, so stay away from those. Here, security gates. Here, request a hand search, meaning show the TSA because they're carrying a pacemaker card or an ICD card. So they're taught to, okay, show it to the officer, to the transportation TSA officer that, okay, I have an ICD, sir, please violate me manually. Okay, you know what I mean?
Yeah.
Like hand search.
Right.
Okay, cell phones. Does this mean they can't use a cell phone? No, it's okay. They can use a cell phone, but they're just told to hold the cell phone 6 inches away. So if my pacemaker or ICD is here, where do I use my cell phone? On this hand. Okay, so don't put it here because it's now very close. Now it won't destroy or damage the equipment. It will just interfere. Okay, here's the exact term. It will interfere with the function. All right, so it won't damage the device. Let me make that clear. All right, unless of course you put the, let's say these large magnets over it. So of course it will inactivate the device. Okay, it will turn it off. Can they use microwaves? Yes or no?
Yeah.
Yes. So those signs you see in HHC facilities, because HHC facilities are old, right? They've been around since the 1900s. Bellevue, how old is Bellevue? Over 120 years old, right? So during those times, yes, because the microwaves we had before the World War were pretty old. Okay, they use obsolete technology. So yes, those things used large magnets, and therefore we can't use microwaves, those kinds of microwaves. But microwaves today are modern, right? They don't emit that much magnetic fields anymore. Office equipment, household appliances, they're fine. So TVs, radios, right? Again, avoid large speakers. Tell them what to do. Let's say they have symptoms of decreased cardiac output, the syncope or the palpitations, dizziness, lightheadedness. Okay, that's reportable. Okay, so call 911. Should we teach the patient how to do CPR? Who? Okay, the family, right? Okay, because can you do CPR on yourself? Oh, not breathing out. Okay, so it has to be the family. Okay, so avoid frightening family members. So don't make it like a joke, like like they'll touch you. Okay, let me electrocute you. So avoid those. All right.
ICD and
Pacemaker, the same. Yeah.
the same teaching.
Right. So instead of this one just saying implantable cardiac device. Okay, so actually this is not, remember ICD, what was the acronym for ICD? It was implantable cardioverter defibrillator. So therefore, when we say implantable cardiac device, this is referring to both a pacemaker and an ICD. Does that make sense?
Yes.
Okay, so this is not the Implantable
for-
cardioverter. Okay, so it's implantable cardiac device. So
And there are two
is
of them.
is the pacemaker an implantable cardiac device?
Yes,
Yes. Are we clear?
so the teaching is the same, the treatment is the same. All right,
Function's different.
function is different, but treatment and teaching.
Yes, the same.